Thank you, Dr. Praveen. Child adoption is one of the blessed events that a person can do. But at the same time, we pediatricians we are not aware of what is happening regarding the child adoption and what are the intricacies and what are the laws. Nothing we don't know. To enlighten us about that, we have Dr. Bennet Xylem, who is a consultant pediatrician in WNC Hospital, Trivandrum. And he was the past president of IAP Thiruvananthapuram branch, and he's one of the most socially committed pediatricians. Yes, sir.
And now Riaz sir has joined. I invite Riaz sir for a few words. Please unmute.
Thanks, Praveen, for the invitation. Actually, child adoption is an area which is being discussed as a hot topic in Kerala now. So it is very important to know regarding what are the rules and what are the caveats regarding adoption of a child. And actually, every pediatrician should be aware of all these things, especially the test which we need to do. What are the because many will come to us with questions like, can you examine the child and give us an idea whether this child is normal, things like that, as well as what are the government rules regarding all this. And Bennet sir is a very resourceful person regarding this, because he is taking care of children at the children's home in Trivandrum, as well as before also he had been doing excellent work in the area of child adoption with writing articles regarding that. And all the best, Bennet sir, and all the best to Trivandrum team for doing this.
Thank you, sir. One more important person has joined, Ashok Kumar sir. I invite sir for a felicitation.
Thank you, Praveen. Sorry that I was a little bit late. I'm audible?
Yes, sir. Yes.
Usually I join earlier, but today I couldn't. In fact, I wanted to be with you for today's program because I was the person who compelled Bennet Xylem to come into the area of adoption when we prepared that book on child rights. Hesitantly, Bennet has taken up the topic, but now he's an authority on adoption, and you have to look upon Dr. Bennet Xylem. And I think Dr. Bennet has to take up it in a bit more serious matter, and I wanted you to build up a team of pediatricians all over the state so that we will have resource persons available in every district, so that we will have easy process in the adoption, easily adoptable for the parents who require the new adopted child. So I don't want to stand between you and Dr. Bennet. Thank you, Praveen, for giving me an opportunity. All the best to Bennet. All the best to Trivandrum IAP. Thank you. Thank you very much.
Thank you, sir. Over to Bindusha ma'am.
I think we will straight away go to Bennet sir for hearing his words.
Okay. Actually, it's the most important topic in nowadays. Mainly, a lot of confusion regarding whether we should go for adoption or should we treat an infertility. Basically, for any couples, especially married couples, after a long time, say around 3 years, 4 years, that is depending on the priority it is there independently in their own mind, and whether we should go for adoption or not. Let us see what is the actual thing about adoption. By definition, adoption means the process through which the adopted child is permanently separated from his biological parents. That is the important point. Permanently they are separated and become the legitimate child of his adoptive parents with all the rights, privileges and responsibilities that is attached to the relationship. The most important thing is it is permanent. Second thing is it's legitimate. These are the 2 points, and they are permanently separated from the biological parents. That is the first definition of adoption. Depending on the organization, the adoption definition may vary, but this is the main adoption, especially from the government of India. See, according to UNICEF, India has 29.6 million orphaned children are there. And there was a study conducted by SOS Children Village in 2011. Around 4% of India's child population is an orphan. So that is the importance of a child who is an orphan. So there comes the importance of an adoption also. Actually, around 29.6 million orphan people are there. Among them, around 4% of among the total population, the 4% of them are from India. And what is the demand for a child? Currently, there are approximately around 20,000 parents in line waiting to adopt, compared to 27.5 million couples who are actively trying to conceive. The problem here is in our culture, we are more interested in getting own child. We are not interested to going for an adoption. In comparing with other nations, see what is the irony of the situation? The millions of children without parents, but on the other side, there is an increasingly rising number of infertile couples. For most of them, whose the adoption is the last choice. Practically, what we have to think in terms of, it is better to adopt little early than a very late adoption. Like once you are old age, then going for adoption will not be that good. So let us see the statistics in India. Adoption rates in India have always been low, but they have been dropping in the past few years. See, there is a study conducted in 2010 and a recent study. It is dropping like anything. In 2010, CARA is the Central Adoption Resource Authority. According to their site, in 2010, around 5,693 in-country adoptions were there. But now it is reduced a lot. It is around 3,276 in 2018. That is prior to our COVID scenario. See, this is directly taken from the site. That's why it's not very clear. You can see here, in-country adoption, it is around 5,000. Now it is in the data in March 21. It is 3,142. It is reduced. In inter-country adoption also it's reduced. Earlier it was 628, but in 2021 it is only 470. So let us see the associations. What are the associations are there with us? One is Kerala State Council for Child Welfare. It is an autonomous body with the Kerala Governor as the patron, Chief Minister as the President, Women and Child Development Minister will be the Vice President. That means our Health Minister. Per year, around 50 to 75 children will be received by our own Amma Tattal in Trivandrum itself. And mainly it's surrendered by parents or caretakers. Main center for adoption is Trivandrum. Commonest adoption is interstate. Second is intrastate. And last is the inter-country adoption. So inter-country adoption also is there. See, let us see the last data. That is, this data is on yesterday I searched it, and it is around last data. It is 58 boys and 62 girls were adopted in the last year. That is 2021, and around 13 children, that is 6 boys and 7 girls, found a new home as NRI. Total is 133 kids are adopted from in our own state. So what is the need of the hour? Need of the hour is basically sensitization. Our today's discussion is also mainly, my aim is to sensitize the importance of adoption. It is not just parents, but also the future generation in schools and other institutions for increased acceptance of adoption in the years come. We need to note here that adoption is not a charity act. So we should not think that it is a charity you are doing. It is not. It is about taking absolute care and responsibility of a child as you give them a home and a family, no different from that of a biological child. So that is the thing we should keep it in our mind. It is not based on a sympathy or anything. Let us see the fundamental principles governing adoption. The adoption should be on child's best interest. This is very, very important, these words. Because if somebody is coming to you and crying, I need to adopt a child, and if his mental, physical, or financial status is not good, we will not be able to give. Our interest is child's best interest. If once you give an adoption, our aim should be that child should get an excellent life like any other child of a family. And preference shall be given to place the child adoption within Indian citizens. That is because basically for socio-cultural situation. All adoptions shall be confidential. That is, the identity of biological parents shall never be revealed to the adoptive parents or the adopted child and vice versa. Because the interaction between the adopted parents or biological parents are not there for any adoption. All adoptions shall be registered on Child Adoption Resource Information and Guidance System, and the confidentiality of the same shall be maintained by the authority. So everything is written, everything is a very confidential thing, everything is registered, mainly in online registration is done nowadays. Okay, child eligibility for adoption, let us see. Any orphan or abandoned or surrendered child declared legally free for adoption by the Child Welfare Committee. So there the importance of Child Welfare Committee will come. A child of a relative defined under subsection 52 of section 2 of the Act, that will come later. A child or children of a spouse from an earlier marriage also can be adopted if they surrender by the biological parents for adoption by the step parent. So these are the conditions you can the eligibility of a child for adoption. So let us see the adoptive parents. What are the terms and conditions are there for an adoptive parents? Adoptive parents is where the child is going. The prospective adoptive parents shall be physically, mentally, and emotionally stable, financially capable. So financial also is very, very important and shall not have any life-threatening medical condition. So our role, since I am a committee member, my role is mainly for the verification and checking of the adoptive parents, not the children. Otherwise also we have to examine. Any prospective adoptive parents, irrespective of marital status and whether or not he or she has a biological son or daughter, can adopt a child subject to the following conditions. So there is an thinking that if I got a child, I will not be able to adopt. It is not like that. Anybody can adopt, but certain conditions are there. First condition and the most important condition is the consent of both the spouses for the adoption shall be required. Because the partners, both the partners have to give consent. But a single female can adopt a child of any gender. A single male also can adopt, but only thing is, shall not be eligible to adopt a girl child. For a male person, they can adopt a male child, but female can adopt either male or a female. No child shall be given in adoption to a couple unless they have at least 2 years of stable marital relationship. This is an important point because we don't know whether if you want to get pregnant, some people may think that they don't want to go for the sufferings of the pregnancy and delivery. They can also adopt. There is no harm in it, but the only thing is they have to wait for minimum of 2 years. Okay, the age of the prospective adoptive parents as on the date of registration is counted. shall be counted for deciding the eligibility. Let us see what are the ages. See, this is the combined age is calculated. Combined age means both mother and father's age is combined together and then calculated. Let us see what it is. Up to 4 years of age, the total combined age should be 9 years. Suppose the mother is 45 years and father is 45 years. So the total year will be 9 years. They can, suppose the combined age is 89 years, they can very well adopt a child less than 4 years of age. But if their age is 100 years, from above 4 up to 8 years, they can adopt. And above 8 years up to 18 years, 10 years means if both the parents are having the age of 55, they can adopt. But here, make single parent, then the prospect is here is 45, that is for up to 4 years, 50 for 48 years, and 55 for 8 to 18 years. The minimum age also is there. The maximum age is already I said. The minimum age should be 25 years. The minimum age difference between the child and either of the prospective adoptive parents shall not be less than 25 years. The age criteria for prospective adoptive parents shall not be applicable in case of relative adoptions. Suppose in our family, some parents died and the child is waiting there. We can adopt them. That is a special rule is there. Normally, they cannot adopt. Couples with 3 or more children shall not be considered for adoption in normal circumstances. Special circumstances like relative adoption and all, they can go. But normally, they don't get any extra one more child. Maximum number of children can be accepted is 3. So, in short, these are the procedures. First, these are all done in online basis only. That is, first is registration. Second is home study and counseling. Once you register, that will be intimated to the specialized adoption agencies. We so-called, normally we say that Ammathotil is an organization. It is it's an autonomous body under Kerala government only, but practically speaking, it is also an autonomous body only. And that is one of the main center in Trivandrum. That is registration, home study and counseling, referral of the child, acceptance of the child by the prospective parents, then filing of petition. It's application basically. After once everything is accepted, then pre-adoption foster care is there. They can stay with the child. Then court hearing, finally court order. So after this court order only you can get a child. These are the procedures to be followed. It will take little time, around 3-4 months it will take, may take more, but it will take some time. Okay, the procedures relating to an orphan or an abandoned child is, these are all the rules, and that is mainly because if you may not remember, it is there in the Adoption Regulation Act 2017. It is there. If you search this act, it is freely available in the internet. So it is not at all a problem for knowing about all these things. What are things also I have taken it from the net only. And procedures referring to a surrendered child is a parent or a guardian wishing to surrender a child under subsection of Section 35 of the Act shall apply to the Child Welfare Committee in Form 23 of the Juvenile Justice, that is Care and Protection of Children, Module Rule 2016. This also is available in the internet. So these are all proper procedures are there. And so where the availability of child for adoption? As soon as a child is declared legally free for adoption by the Child Welfare Committee, in the recent case also like that, it is declared by the Child Welfare Committee after seeing all the procedures. Then only they will declare the child shall be allowed to be given in adoption to a resident Indian or a non-resident Indian parents. It can be given to anybody. It is not that it is only to be given to the India. So inter-country adoption is the basic rules are like this. The child shall be allowed to be given in inter-country adoption after 60 days if the child is below 5 years of age. After 30 days if the child is above 5 years of age or is a sibling. After 15 days, if the child has any mental illness or physical disability as listed in the schedule, that is in the you can available with our proper form. So then comes the registration and home study of the prospective adoptive parents. The Indian prospective adoptive parents, irrespective of their religion, shall apply for the same to the specialized adoption agency, like our Amatotal. That is a specialized adoption agencies. Through the child adoption resource information and guidance system, by filling up the online application form as provided in Schedule 6 and uploading the relevant documents, including photograph, thereby registering themselves as prospective adoptive parents. Then comes the seniority. The seniority of the prospective adoptive parents for child referral shall be from date of uploading of documents. So including that age, parental age also will come there. Date of uploading, that is the cutoff date, that is applicable for any application. And completion of registration process in the child adoption resource information and guidance system. So then comes the pre-adoption foster care. A word about that. The child shall be taken in pre-adoption foster care by the prospective adoptive parents within 10 days from the date of matching. So actually, the adoption committee also does like that. They'll see the parents and they will take the child almost similar to them only. After once we hand over to them, others should feel that it is their child. That type of matching we do after signing the pre-adoption foster care and undertaking. The prospective adoptive parents shall provide original documents or notarized copy of the documents to the specialized adoption agency. So then comes the legal procedure. The specialized adoption agency shall file an application for obtaining the adoption order in the court under whose jurisdiction is the specialized adoption agency is located. Suppose some district, if they are not having any specialized adoption agency, they can take the help of nearby district, like our NRP program. If the resource person is not there, you can take it from the other district, other IAP branch. Similar way, if the same district is not having any specialized adoption agency, they can take the help of the another district where the specialized adoption agency is there. It is applicable for inter-country adoption. It shall be within the 10 working days from the date of receiving the no objection certificate. In case the child is from a child care institution, which is not a specialized adoption agency, it can take the help from the other district, already said. Then in case of siblings or twins, the specialized adoption agency shall file a single application in the court if they are adopting, because and the system doesn't want to separate a twin child. Let them go like that only. So in that case, if the single application is enough, the court shall hold the adoption proceeding in camera. So that much documentation is there and dispose of the case within a period of 2 months from the date of filing of the adoption application by the specialized adoption agencies. The adoptive parents shall not be required to execute any bond in the name of the child. There was a concept about it. So many people thought that because some asked me about it also, whether they have to produce a bond. It is not required nowadays, because considering the fact that their psychosocial profile and financial status have already been ascertained from the home study report. So home study is important. Our field staff is there. They are MSW qualified persons are there. They will go to the field and study about what is the situation and what is their interest, whether really they are interested or not. That type of things, they will get the information. The specialized adoption agency shall apply to the birth certificate. Issuing authority for obtaining the birth certificate of the child is within 3 working days from the date of issuance of adoption order, with the name of the adoptive parents and date of birth as recorded in the adoption order, and the same shall be issued by the issuing authority within 5 working days. These are all procedures. practically about date of birth, a lot of confusion may be there about the date of birth giving. Like since I am a medical officer of that Amma Total also, I can say the example. Some children we get without knowing anything, like they don't have any documents, they don't have any like a birth certificate, nothing is there. We receive the child in the Amma Total. Means no address is there. No, it's not like a surrendered child or handed over child like that. In that case, the committee or the medical officer who is going there for seeing the child, or even the leaders who are there in the office, they can give a temporary birth date. Practically, that will be finalized also. That also can be done. Follow-up of progress of the adopted child. So it is not that it is once you are given for adoption, you can forget it. It's not like that. The specialized adoption agency that has prepared the home study report shall prepare a post-adoption follow-up. So after the giving also, you have to follow it up on 6 monthly basis for 2 years. In our case also, it is not 2 years, it is not at over. From the date of pre-adoption foster placement with the prospective adoptive parents in the given format and upload the same in child adoption resource information and guidance system along with the photograph. Practically what we have to think is every 6 months there is a study about how the child is going, whether child is the parents are taking care of the child is healthy, is okay. All these things are studied by home study people, including photograph they have to take. In case the adoptive parents relocate, they shall inform the agency which has conducted their home study and the district child protection unit of the district where they relocate. The latter shall then prepare and upload the post-adoption. Suppose if you are going from Thiruvananthapuram to Kollam, then the adoption agencies there also is there. They can take it. And child protection team is there in Kollam also. They can do the study. That way it is a good network is there, especially in Kerala. Whenever required, example, the child is having an adjustment problem, the specialized adoption agency or the district child protection unit, as the case may be, shall arrange for counseling the adoptive parents. Naturally, especially this is happening with some older children. If the child is going like a less than 1 year type, will not face much problem. But after that, especially they may stay even up to the age of 5 years in our Amatot like institutions. Then the adjustment problem may come. Here, adoptee by a social worker or link them to the counseling center. Basically, what we have to keep it in mind is counseling will take place if any adjustment problem between the child and parents or the family. In case there is a disruption in the adoption procedure at the stage of pre-adoption foster care, the specialized adoption agency shall take back the child. So it is not that once you given it is given. It's no. We can take it back. If there is a dissolution of adoption later, it shall apply in court for annulment of the adoption. In either case, the child once again becomes legally free for adoption. It can happen like if the child faces any problem with their parents, the adoptive parents, then definitely the child will be taken back. So let us go for the NRI adoption. Non-resident Indian prospective adoptive parents shall be treated at par with Indians living in India in terms of priority for adoption in Indian orphan, abandoned or surrendered children. It is same. Not much difference, practically speaking. So registration and home study report for prospective adoptive parents for inter-country adoption. Like there is a Hague Convention is there. Around 90 countries signed in this Hague adoption. Like in this picture, you can see this the countries where thick blue mark is the countries, including India, and certain African countries, Arabian countries are not included in that list. That is Hague Convention countries. Any non-resident Indian overseas citizens of India or foreign prospective adoptive parents living in a country which is a signatory to the Hague Adoption Convention and wishing to adopt an Indian child can approach the authorized foreign adoption agency concerned for preparation of their home study report and for their registration in the child adoption resource information and guidance system. Practically, I will tell you certain things. Some disabled people like dwarfism or like cerebral palsy, that type of children are getting adopted to the foreign countries actually, not to the Indian intra or inside India. These children were disabled children were mainly taken by our foreigners. So we should have a good respect on them also. In case there is no authorized foreign adoption agency in their country, then the prospective adoptive parents shall approach the Indian diplomatic mission concerned in that country for the same purpose. An overseas citizens of India or a foreign national who is a citizen of a country that has ratified the Hague Convention and is a habitual resident shall apply for adoption online in prescribed format as specified in Schedule 6 along with the required documents specified therein by uploading in the Child Adoption Resource Information and Guidance System. Practically, it is same. So, procedure for adoption of a child from a foreign country by Indian citizen. So, what is the procedure? Here also, necessary formalities for adoption of a child from a foreign country by Indian citizen shall initially be completed in that country as per their law and procedure. So, depending on which country they want to take the child, it is the rules will be different. They have to take the rules of that country. And here, once they come here, on receiving the home study report of the prospective adoptive parents, including supporting documents, the child study report and medical examination report of the child, authority shall issue the approval as required in the case of adoption of children coming to India as a receiving country, like under Article 517 of the Hague Adoption Convention. There it is separate again. It is available in the internet. A child adopted abroad by the Indian citizen having a foreign passport and requiring an Indian visa to come to India shall apply for a visa to the Indian mission in the country concerned, who may issue entry visa to the child after checking all the relevant documents so as to ensure that adoption has been done following the due procedure. Practically speaking, the procedures are same. Once we want to migrate to the other country, there are certain procedures are there. Like we have to apply for the visa, NOC, all these things. The same thing is applicable for the adopted child also. The immigration clearance for the child adopted abroad shall be obtained from the central government in the Foreigners Division Ministry of Home Affairs through the Indian diplomatic mission to that country. So now let us come to the final part. That is, what is the role of a pediatrician? Our role is very simple. Counsel adoptive parents about the process of adoption. Whatever the information we know, we should share because they may ask. Then only thing what we have to say is it is available in the internet. CARA and SARA is there. CARA is the Central Adoption Regulation Agency is there, and SARA is the State Adoption Agency is there. So these things they can search it. The forms are available there. They can download it and apply it. So that is about the adoption. Then counsel parents who wish to relinquish the child due to any reason. Okay, that also too important. If we feel that if the parents say that they don't want the child, then we have to first counsel them, and still they are saying that they are not able to bring up the child. They can definitely go to the child welfare center is there, our Ammathottili is there. All these options are there. Then private adoptions are also, since these are illegal, tackle them carefully. This is like, I think many of us has come across this situation. I have come across, I directed them to go in a proper way. What happened is they may get a child without any rules and regulations, and they will take the advice from us. Definitely, it is mainly their headache, but some way it is our headache also. We have to take them very carefully. If required, we have to inform the main authorities. If a baby is brought by a prospective parents, this can happen. Like it happen to anybody. Before a foster care, they may take the child to us for checking up. So if a baby brought by prospective parents contemplating adoption, check the child's available medical records first. Do a detailed physical examination, assess his developmental status, and ensure that he has been investigated adequately before giving a reasonable prognosis to the parents. So we have to do thorough examination, clinical examination. Repeat all essential tests. This all I think Riaz already mentioned. Repeat all essential tests that have a window period. Like you can do the blood routine. What we do practically is Rajman sir also is there in the Amma Total. Sir also is to do this. That is urine routine, blood routine examination we will do. In addition, we will do the HIV test and hepatitis. It is after 3 to 6 months before the placement for adoption. And always be supportive and encourage adoptive parents to overcome their fears. Biological parents may give birth to a child with Down syndrome or other intellectual or physical disability, but adoptive parents are at an advantage as of avoiding these situations, and it can be ruled out before the adoption. So they will get a healthy child in comparison with own child. And that's all. Thank you very much for the patient hearing. Thank you.
Thank you, Bennet sir, for giving us an outlook into the what are the eligibility of the parent, prospective parents, and what are the roles of pediatrician in a child adoption. Should we have the discussion now or after the completion of the second talk also?
We can have after the completion, madam. Now our state president has joined. I invite Jayaraman sir for a few words.
Thank you, Dr. Praveen. Thank you, Dr. Praveen, and the respected president of IAP Trivandrum, Dr. Santosh, all the other dignitaries. I'm happy to participate in this discussion on a very important issue in our, I think in our routine practice as well, one of the important issues. And this is actually the right to family is an important child right. And this is something, a very important topic to be discussed during the Child Rights Week of this year. And I thank Dr. Praveen and Dr. Bennet for arranging this session at a very short notice. And I'm very happy to see that we are having a very good attendance also. I was hearing the lecture by Dr. Bennet, and he has mentioned almost every practical aspects and the legal aspects regarding adoption. And I hope it is useful to everybody. Thank you so much for this opportunity, and I wish the very best for the program. Thank you.
Thank you, sir. Rajmohan sir.
Praveen, I'm sorry. I was late because I went to the temple, and when I came back only I could see your message. So I have seen only half of the Bennet's presentation. Bennet is doing a very committed service in the State Adoption Center, where I am also doing some service. This is a very important area where doctors are not at all aware of many things. And sometimes I feel that people who are dealing with these things don't expect doctors to involve also. At the same time, there are a lot of things that doctors can do. There is a quite unfortunate thing. There is an iron curtain between the key players of adoption in our state and the clinical people. And actually, I am, since last 4 or 5 years, I am doing the medical evaluation reporting of children for adoption. Unfortunately, the thing is that they only want us to do the clinical material. And they never identify as advocates for children. That's a very sad state of affairs. And see, unless we come for the lobbying work, as Dr. Venkatesh was doing, because Dr. Venkatesh, past president IAP, was doing a lot of work in this regard. But unfortunately, that also didn't click much. The sustainability of that, his efforts were doubtful. So we all know about it. IAP state people have all know about all those things. So this is an area where there is a plenty of scope for us to work, and any work as a collective effort only will produce results. Bennet is in the track. So my humble request is to join with Bennet in all these efforts, because that is one lost world for me. Social pediatrics, I couldn't do much, contribute much, because I was fascinated by the field of epidemiology and research methodology. So I couldn't concentrate much on social pediatrics. And Geeta was there, but Geeta is now not in Thiruvananthapuram. And quite sad that after Elizabeth, nobody came to vouch for social pediatrics in the department. And I am very happy that health service faculty are doing that, and Bennet is one charlatan and cheerleader. And my all congratulations to Bennet. Bennet is actually doing work in State Adoption Center, the Women Service. Actually, his work is commendable, and it is appreciated by the government. Thank you, Bennet, and thank you, our dear President, for seeing us through online at least. Dr. Jayaraman, and also my dear friend Santosh. I am very happy that a lot of people have come to research, and Veena has got a first rank in PhD entrance examination. It's a very, very laudable moment for all of us. I don't know Veena is there or not, but Veena got first rank in the PhD entrance examination, where a lot of big competition was there. When community medicine teachers, who are actually the doings in that field, they couldn't come to the first rank. And Veena, I am very proud of Veena, and kindly convey my regards, Bindusha, to Veena. Thank you all for giving me the opportunity. Thanks.
Thank you, sir. Now over to Bindusha madam for the continuation of academic program.
So we'll move on to the second talk of today. And the second talk is by Dr. Pediatrician, sir. He is the surveillance medical officer of WHO. He will be talking to us about vaccine preventable disease surveillance program. What is new? Vaccine preventable disease surveillance is an integral part of an immunization program, where we need to know the incidence of vaccine preventable disease. And whenever we have a vaccine preventable disease, Dhaval sir is very familiar to us. Whenever we have a vaccine preventable disease, we inform sir, and by one message, sir will take up the case and will complete the reporting. I request sir to give us a talk on the topic.
Thank you, ma'am, for the nice words. Respected teachers, my friends in IAP. After a very wonderful current topic by Dr. Bennet, please adopt legally this topic, which is not that hot. Okay, can you share my screen?
Yes, sir.
Is the screen visible?
Yes, sir.
Okay. So the topic for the day is VPD surveillance. You want to eradicate a disease, eliminate a disease, control a disease. There are few basic steps. The most important for any vaccine preventable disease, the first step is immunize. The second, early identification, control the spread. For that, surveillance is the major one. And the third will be managing that particular case to save the child. So these are some of the basic steps for any condition, any vaccine preventable disease control, elimination, or even eradication. Many of the young pediatricians, they have not seen this. Or none of the young pediatricians have seen this. This is what polio can do to a child. And this. And this. None of the young pediatricians have seen this. But these are all True things that happened, and it was happening even during our house agency and postgraduate days. But now you may not have seen this. These are iron lungs, olden age ventilator equivalents. And another one, almost everyone in that family got wiped out because of one vaccine preventable disease, diphtheria. A simple vaccine would have prevented this, and this happened in 1800s. It continued in 1900 also, another family. So in this background, our surveillance becomes very important. Immunization, we should concentrate. At the same time, with the same importance, we should pursue surveillance also. At present, we have 5 diseases coming under the BPD surveillance. The first and the most important is for polio, that is AFP surveillance. Then for measles, rubella, earlier it was MR surveillance, now it is fever, rash surveillance. Then for diphtheria, pertussis, and neonatal tetanus. And for polio, what we have is an AFP surveillance or acute flaccid paralysis surveillance. Under this surveillance, we need to report any sudden onset of weakness or floppiness in a child under 15 years of age, irrespective of the part of the body, irrespective of the associated symptoms, irrespective of the immunization status of the child. Even a borderline case, even an ambiguous case, even a transient paralysis, it is to be reported. Maybe we can say only 2 exceptions for not reporting. One, if it is more than 6 months, the onset of paralysis is more than 6 months, it's not an acute case anymore, no need to report. And the second, if there is any element of spasticity or rigidity, no need to report. Every other weakness in a child, even when the tone is normal, even when the reflexes are retained, still, if there's any kind of paralysis, please do report immediately. If the child is above, or if the person is above 15 years, only if the clinician is suspecting polio, then only it should be reported. And when you report a case, this is what we do. The sample collected is stool. We need to collect 2 stool samples within 14 days from the onset of paralysis, ideally. Up to 60 days or 2 months, we do collect samples. And these 2 samples should be minimum 24 hours apart, a minimum quantity of 8 grams for adult thumb size, and it should be shifted to a WHO accredited lab in a cold chain, in a reverse cold chain, 2 to 8 degrees. And the accredited lab for Kerala is NIV, Bangalore. So we need to send that sample. And the lab will process the sample for wild virus, vaccine virus, VDPVs, and other enterovirus. Then only they give a negative certificate for that. And these are the criteria to say that stool samples are adequate. And for measles and rubella, earlier we had MR surveillance, and now since last 2 months, government of India has changed MR surveillance to fever rash surveillance. This is a very major change. Earlier, we used to report any person, irrespective of the age, with fever and maculopapular rash, and one of the 3 C's, like cough, coryza, or conjunctivitis. In the present fever rash surveillance, this criteria has been taken out. There is no cough, coryza, conjunctivitis criteria. So any person with fever and maculopapular rash, irrespective of your diagnosis can be dengue, can be chikungunya, it can be measles, it can be rubella, it can be maybe missed. But when someone has fever and a maculopapular rash, it is to be reported as suspected measles, rubella, or even a fever rash syndrome. Or any person in whom a clinician suspects measles or rubella is to be reported. And this was the criteria for rubella reporting. Again, fever with rash and lymphadenitis, arthralgia, or arthritis. Now that criteria has been taken out. Now it's only any person. So any person with fever and maculopapular rash is to be reported for fever rash surveillance. This is a major change in MR elimination surveillance. And the samples collected. For any fever rash case reported, we collect 2 sets of samples. One is a serum sample, and it can be collected up to 28 days from the date of onset of rash. And this sample goes to NIV, Alappuzha. Only for Trivandrum, the sample goes to State Public Health Lab. And they do IgM for measles and rubella. And we can collect the sample up to 28 days and to treat the lab again in a cold chain 2 to 8 degrees centigrade. And the second sample is for virological study. And the ideal sample will be a throat swab or an nasopharyngeal swab. If it is not available, or if it is difficult to take the sample in a very small child, then you can go for a urine sample, which is not that productive as a throat swab. But this can be collected only up to 7 days. With this sample, they do an RT-PCR. And if it's a throat swab, it should reach the lab in a transport medium, which is a viral transport medium, the same transport medium which we use for COVID testing. And all the other districts give it to NIV Alappuzha except Trivandrum. For Trivandrum, we have State Public Health Lab as an accredited lab. And this is what the lab do. Whenever there is a serum sample, they run it for IgM measles first. If it's confirmed, if it is positive, it's a confirmed case of measles. If it is negative, they run it for rubella IgM. And if that's positive, it's a confirmed case of rubella. If both measles and rubella IgM are negative, then they report it as a negative sample, then that case becomes a non-measles, non-rubella exam. And for diphtheria, if a clinician suspects diphtheria, it is to be reported. Otherwise, this is the criteria: a laryngitis or pharyngitis or tonsillitis with an adherent membrane of tonsil, pharynx, and or nose. And this is to be reported as diphtheria. And for every case of suspected diphtheria reported, we need to collect 2 throat swabs. More the number of swabs, more the chance of isolation of organism. Once you collect the swab, it should be transported to State Public Health Lab, which is accredited lab, in 2 to 8 degrees centigrade and in a transport medium. And the transport medium which we use in Kerala, its aim is transport medium. Without a transport medium, if it is shifted to the lab, by the time it reaches lab, if the swab dries out, we cannot process the sample. So that's the importance of transport medium. And please make sure that we are using correct transport medium. For example, if you take a diphtherial swab and put it in a viral transport medium, by the time it reaches the lab, there won't be anything. So the correct transport medium is also very important. Similarly, to take the throat swab, ideal would be a dacron or a polyester swab. If you use a cotton swab, it might hinder with the RT-PCR test. And for pertussis, if a clinician suspects pertussis or pertussoid cough, immediately it should be reported. Otherwise, these are the criteria. A person of any age with a cough lasting for more than 2 weeks, or of any duration in an infant or in a person in an outbreak setting. In an outbreak setting, if somebody else has pertussis in that area, no need to wait for 2 weeks of coughing before reporting. You can put it as a suspected pertussis. And with one of the following, like paroxysms of cough, inspiratory whoop, post-acid vomiting, or apnea in an infant. So in that case, the sample collected is a nasopharyngeal swab and a serum sample. 2 samples are collected. One is a serum sample, and it can be collected up to 12 weeks. After 2 weeks of cough, onset of cough, up to 12 weeks, we can collect the sample. And from the serum sample, lab will be doing an IgG. And we need to take a nasopharyngeal swab, not a throat swab. We should take a nasopharyngeal swab, and it should reach the lab in a transport medium. The transport medium for pertussis, what we use is a Regalo transport medium. And again, these samples should reach the State Public Health Lab. And for neonatal tetanus, these are the criteria for reporting neonatal tetanus. 1, a newborn with a normal ability to suck and cry during the first 2 days of life become stiff or have convulsions or spasm and cannot suck normally between 3 to 28 days of age. Or a child died of unknown cause during the first month of life. Even that is to be reported as suspected neonatal tetanus. Later, after investigation, maybe we'll rule out for some other etiology. And no samples needed. Okay. Why every case is to be reported? It's unlike in clinical pediatrics, whenever a case is reported, actually, we are not managing that case. We are not just taking the sample and sending it to the lab and just confirming or discarding it as a case. Same time, other things also happen. The most important thing, we track all the contacts and line list them. Whether it's diphtheria, whether it is pertussis, whether it is measles, whether it is rubella, whatever. Or for all the cases, we track all the contacts and line list them. And at the same time, we do an active case search in the locality, in all the houses, nearby houses, or in that ward or village, for additional cases. Then we try to prevent that case becoming an outbreak in that area by doing timely intervention like outbreak response immunization for diphtheria. Any child who is left out or drop out will be immunized with either Penta, DPT, TD, or whatever age appropriate vaccine. If in an adult, if that person has not received any vaccine for the past 5 years or more, that person, so that way we give an outbreak response immunization. Then we do chemoprophylaxis. If it's a diphtheria case or if it's a pertussis, all the contacts will be given chemoprophylaxis, whether erythromycin, azithromycin, whatever as per the guidelines. And at the same time, we isolate the patient, and maybe we quarantine some of the contacts. And most important, we create an awareness in the community, among the public, because anybody with a sore throat, if they have a diphtheria in that area, if they know that there is a diphtheria in that area, they might go to a doctor rather than go to a pharmacy and get some drugs. Similarly, a doctor, if he knows that there is diphtheria cases reported from that area, before writing some antibiotic for a person complaining of sore throat, at least they will ask that person to open the mouth and put some torch and see whether there is a membrane or a patch. So that awareness also. So these are things that happen when you report a case, not that we just see that case, collect sample, get a report and discard. These are things that happen in the background when even as for a single case that's reported for any of these VPTs. Okay, then what are the challenges? It looks very simple, but we have lots of issues. One, getting the case reported in time. Many a times, fever rash cases, lots of fever rash cases are happening, but we don't get the cases reported. Maybe they know that it's measles, or they know that it's a transient rash, or they know that it is a misc, or maybe it's something else. So it's not getting reported. Second, paralytic cases. If it's a facial, I know it's a Bell's palsy, why should I? Or maybe I have done all the nerve conduction studies and cytoalbumin disproportion, so it's a GBS, why should I? No, for this, it's a syndromic approach. So getting the case reported, that's the first challenge. Second, once you report a case, investigations should be done at the earliest so that we don't miss out on any of the clinical findings. And the most challenging part will be the sample collection. We need to collect the sample within that proper time window. For that, we need the proper reporting, correct, timely reporting, and we need to have the timely investigation. Then only we can collect the samples within that time frame. And we need to have the adequate sample. And another challenge will be the shipment of the sample. You have collected the sample, you have taken the serum, you are taking the throat swab, you are taking nasopharyngeal swab. One, there should be a proper packing. We have instances where the samples have been collected, it has been sent to the lab. But by the time it reaches the lab, the entire sample has leaked out because they forgot to screw cap the bottle tightly. Very simple mistake, but all the effort done so far, it goes waste. You have taken a throat swab, but you didn't put it in a transport medium. You have taken a throat swab or a nasopharyngeal, you put it in a wrong transport medium. All these things will affect. Even a simple thing like not labeling the sample bottle. The lab receives hundreds of samples per day. If your sample is not labeled for the lab, it's an unknown sample, they will not process it. So these are small things, and sending the lab sample to an accredited lab. You have taken a sample and you sent it to your hospital lab or to a private lab. Okay, that's fine maybe for you. But as far as the national program is concerned, the report should be from an accredited lab, then only it has a value. So we need to know to which lab it's to be sent. And all the documentation. This is also important because in that regard also we need some support from you. Then, so what's the request to each one of you? This is the request to each one of you for a very good surveillance or a very strong surveillance in our state, especially now, because since last 2 years, our routine immunization have dipped like anything. All of you know, from 93% full immunization coverage has come down to 83%. In some pockets, it is even less than 70%. That's one thing. Now schools are opening up. Now theaters are opening up. So people have started moving out. So this is the time when we anticipate some trouble as far as VPD is concerned. So at this point, this is very crucial. So request will be, please do report any suspected case as per this definition, or even when you suspect none of the things fits in, but you feel that it's a case of paralytic case, or if it's a diphtheria or it's a pertussis or a measles or rubella, please do report immediately. And second, support in sample collection. This is very important because you have a child comes to your clinic or to a hospital. You are treating as an OP. You have reported. Unless you tell them, even if our team goes to the field and requests for a sample collection, even if it's a stool sample, they may not. They may not. Basically, we are all paranoid. And now this paranoia is a little more also. So unless you give them a clue that, okay, somebody will come, please do give the samples. That's one thing. And second, for the fever rash, we need serum sample. It's very difficult to collect serum sample even in a hospital setup in a small child. So it's almost out of question doing it in the field. So the request will be, anyway, the fever rash child will come to a hospital. Any child or any patient that comes to your place, you might take the blood sample for the routine investigation. So the request will be, take 1 ml of serum from that child, label it and keep it in the fridge, so that we can avoid that painful procedure, painful both for the child, the parents, the bystanders, and even for the our health team who is going out there. We can avoid that. And the last thing will be support in case investigation and documentation. Most part of the case, it's a very simple one-pager. It's a very simple one-pager, but the issue is some of the things can be filled only by a medical officer. So at that point, for our health team, just help them out in filling up that tone, reflexes, those parts. So these are the small things which can help the servants in a very big way. And again, the request will be report the current illness, even the history of illness. For example, a child comes to you with a cough or a diarrhea, and the mother says last week child had fever and rash. Report that. Even up to 3 months backdated cases can be reported, even though we can collect the sample only up to 28 days. Even borderline ambiguous or even doubtful cases, especially in an AFP case. Child is limping, but the reflexes are retained. Tone is okay. You don't know why child is limping. It's a myalgia, maybe neuritis, maybe it's your diagnosis synovitis. But when you take an X-ray or an ultrasound or a scan, there's no fluid. Please do report. So borderline ambiguous, even transient paralysis, please do report. So why we are not looking for the case per se. We are not keen on that particular child. We are for a bigger cause. We are looking for the virus transmission. We are looking for elimination or eradication of a condition. So even when you are in doubt, please do report so that we can collect the samples within that time frame. If it's something else, we can always discard that case. But if the reporting is delayed, then the sample collection gets affected. So this is what happens in a surveillance. We have lots of patients. Some of them have the symptoms like we mentioned. Please do report so that they come in the surveillance net. So we do take the sample and test it. So we know which is a case and which is a discarded one. Okay, so that's my request. If you happen to find any of these cases, please do report immediately. Please do report. Please don't wait for a confirmation. Please don't wait for a lab report from your lab. Please do report immediately, either to the district RCH officer or directly to me. Thank you. Thank you so much.
Thank you, Thiruvananthapuram sir, for that excellent presentation. Sir has actually told us what are the conditions where you need to report and how to report also. We will all take up your advice and report cases as and when they come to our OPD and clinics.
Thank you.
Now both topics are open for discussion. There are a few questions in the chat box. I will start with that. There's a question that is, can prospective adoptive parents select to reject a particular child before adoption?
Definitely, they can select or reject. The child will be shown to the parents, prospective adoptive parents, and if they are not interested with the child, definitely they can select or reject. There is no confusion.
There is another question whether the child can reject or adopt or accept a prospective couple.
That
it is another child.
I am not very sure about it, but usually the children are less than 5 years and all, they don't do like that. But definitely this question I am not sure about it. Whether the older child they can adopt, accept or reject. I'm not sure.
Sir, as you said that rates of adoption is now decreasing. Over the years, there is a decrease in the number of adoptions. It's happening in our country. What is the cause for this? Is it due to decrease in the number of children who are eligible to be adopted, or decrease in the prospective parents?
Exact cause we don't know, but last year because of the COVID scenario, the adoption process itself got delayed. That is a last 2 years situation, but the trend is definitely downgrade only. And exact cause we don't know. Maybe because of the poor awareness and our sensitization may be low. That may be the reason.
Yeah, these were the questions.
Maybe one more reason can be more and more people are going for infertility treatment because the facilities are now more and the institutions are giving a lot of hope to the infertile couples that you will get a child if you come to me. Like that situation also can be there. Exact reason we don't know.
We have always heard that there is a waiting list of parents for adoption. Is it like that even nowadays?
It is true. It is true because of the procedure delay. That is there. Lot of waiting. This personally, I got a chat from Muscat also asking for. They waited for 3 years and it got expired, but that seniority will be maintained. That will not be any problem. And but they have to apply again.
Purushothaman sir, I want to say.
Bindusha, both the talks excellent. Bennett and there is highly informative. A lot of informations I had. Pradhaban, I have two doubts. One thing we covered MR vaccination in Kerala almost 76 lakhs. And out of India, 41 crores we are targeted. I don't know how much was the coverage, whether we achieved 95% was doubtful. Anyway, in Kerala, it was almost we covered around 90% of the 76 lakhs. At that time, what we left out was above 15. And definitely, they were the eligible people because there is a chance for the age shift of the rubella in the coming years. Nobody took any interest to arrange the vaccination for that age group, and now it's almost 4 more years gone. So my question is whether there is a number of rubella cases increasing among that age group, whether there is an increase in the number of congenital rubella syndrome, who is having the data in state? We don't know. And is there any provision for the surveillance of this age group? You're all doing this thing up to 15 years. So what about the communicable diseases, which is shifting to an older age? Whooping cough is shifting to the older age group. Diphtheria, all of us know it's in the older age group, even in the above 60s. So we are all targeting the surveillance for the younger kids less than 15. And only in the clinician or the neurologist suspect they have be like that. But maybe we are missing a lot of all these cases above 15. Is there any provision for including them in this surveillance program? We may be missing it. That's one thing. And another, why you people are ignoring the Zika? Zika, for the last few months, it was there in the news. And once the news it's over, nobody's interested. Around 65 cases in Kerala, I was following. And recently, they're in UP and in North India, it's there. And very, very high chance that it is there still in Kerala. But why you people are not at all taking interest in what is the status now? Isn't that important?
Thank you, sir. As always, very pointed, relevant questions from you. So the first thing regarding the surveillance. Sir, except for AFP surveillance, there is no age restriction. Whether it is fever rash or so-called MR surveillance, VPD surveillance, and of course, not neonatal tetanus. For all the others, there is no age restriction. So we request everyone, including dermatologists, including general medicine, even in ENT people, to report cases, and ID people, in addition to our pediatric fraternity, to report cases. So from every case, we do collect samples. That is the surveillance guideline, and even my slides I showed that there is no age restriction in all the other things. So that's one part of the question. Second, regarding the vaccination, when we introduced MR vaccine, actually there's a campaign mode, as you remember, sir. Like we immunize children up to 15 years of age, and only after that we introduced MR vaccine routine immunization, so that we can prevent that age shift and maybe increase incidence of congenital rubella syndrome when those children become eligible couple and when they get pregnant, when they get babies. Okay, so these are the two things. And if we can clearly show that there is an age shift, then at the national level or even at the state level, we can plan for another campaign at a different age group. But for that, we need data. That's where we fail. In spite of all these requests, none of the districts, the minimum criteria to say that there's a good surveillance is 2 fever rash case per 100,000 population. Just 2 cases per 100,000 population. None of the districts have not even one. The highest what we have for this year is 0.8. So that's the level of reporting what we have. So that's the one big failure. Without data, we cannot say that, okay, there's an age shift and we need vaccination at a higher age group. So if we can prove it, we can show it, definitely we can. That's one part. And second, about the Zika. Sir, when that Zika outbreak happened in the state, we had that, as you know, the state level and high level committee from Government of India and all that. So one of the recommendations we put forth to the government, anyway, we are collecting fever rash case sample. And the labs were willing, both NIV, Alapur and state public health, they were willing to do with each serum sample 4 tests: measles, rubella, chikungunya, dengue, and Zika. But that time, what happened? We had some shortage of Zika kits. Then they said, we will do compulsory Zika for all the pregnant women and Zika for those who are negative for all the other 4. But unfortunately, these are not accepted by the state. So, but still, we are still pursuing it because anyway, that way, the reporting will also become better. From the big group of OBGs, once this Zika and Zika also comes into this fever rash, they might also report more number of cases. So still we are pursuing it. Hopefully, it might come through. Thank you, sir.
Bindusha ചോദിച്ചില്ല question ഒരെണ്ണം അതായത് അത് ഞാൻ ഇപ്പൊ എൻക്വയറി ചെയ്തു they can reject if children consciously if they are saying that I don't want to go with this children, they can reject.
And Dr. Bennet, you said there will be some compatibility determined before adoption. So how much choice do the parents have? Suppose they like a child and you say they are not compatible with this parent. So how much choice do they have?
Sir, actually what they do is they will show the child, one child. The first question is what child they want. They can ask for the preference like male child, female child, female. Or no choice. Both they can do. And if they they ask for a male child, definitely they will get a male child only. And if they ask for a female child, they will get a female child only. If they don't give any choice, any child who is coming first, that will be given. And once again, they can see the child also. Everything will be online. And if they reject, they can reject it. It is not a problem at all.
No, actually, seeing the child online is not possibly good enough. So they like to see physically. Photograph നമ്മൾ കല്യാണത്തിന് കാണിക്കുമ്പോൾ ഇരിക്കും. അത് photograph actually. So my second question is regarding that illegal adoption. Suppose we come across, actually I have come across an illegal adoption during my practicing days, and it's now about 18 years or maybe more than that. So when we come across an illegal adoption, suppose we do not report as I have done, is it punishable or what?
It is punishable, sir. Because we are encouraged like any other situation. It is punishable. There is no doubt about it.
Okay. Now, Dr. Pratap, regarding this transport mediums, we will not be having transport mediums in stock like viral, bacterial, and bacterial itself separate for diphtheria, separate for pertussis. So, I mean, are we supposed to stock it, or are we supposed to just report and you will come with the transport medium?
Sir, actually, one of the silver linings of this COVID pandemic is that we do have viral transport medium and swab everywhere. And all of us have become experts. Even our field staff have become experts in taking both nasopharyngeal and throat swab. That is one, what should I say, not good things, maybe the silver lining in that big dark cloud of pandemic. So that way, that transport medium is not an issue, sir. Regarding the other two, that ENIS and the legal or transport medium, the issue is, one, it should be stored in a cold chain. Second, it has an expiry, short expiry, hardly maybe around 6 months expiry thing is there. That's one reason we are not keeping the transport medium in every hospital. But if a major hospital, a teaching hospital like SAT hospital or major medical college, or where we might get cases, maybe 1 or 2 cases per month or something like that, we can always keep samples, transport medium kits in those hospitals. That's not an issue, sir. We can do that. At present, it will be available to all the district RCH offices. So information within 24 hours, you will get that transport medium and swab. If not within 12 hours.
And regarding a child dying within 1 month without a diagnosis, suppose we report, how do we actually come to the conclusion whether it was neonatal tetanus? Because basically it is a clinical diagnosis. Only the person who has seen the child can diagnose it. And the person who has seen the child has got no diagnosis. Then how can we confirm, a third person can confirm whether it is a tetanus, possible tetanus or not?
So that's a bouncer. So, but the same thing happens even for AFP cases also. Many times what happens, when it is not done at our level, or there is some issue, like maybe it is not reported in time, we couldn't see that child, then there is a protocol for that. For example, if this child dies, and we are reporting as a neonatal tetanus, then the immunization status of the mother, that will be taken. The routine immunization status in that village, it will be taken. Epidemiology of that area, this entire document, and including whatever clinical records we have, whatever little we have, entire thing goes to an expert committee. And they will be the ones who will be finally deciding whether it could have been a neonatal tetanus or we could rule it out as something else. If something is there to rule it out, most likely they will say that it could have been neonatal tetanus.
Bennet, 2 years back. Dr. Bennet, or experience, or 2 years back, or experience about 2 blind people. രണ്ടുപേരും കൂടി കല്യാണം കഴിച്ച രണ്ടുപേർക്കും ലോട്ടറി ടിക്കറ്റ് ആണ്, അങ്ങനെയാണ്. അപ്പോൾ ഹാപ്പി ആയിട്ട് ജീവിച്ചു പോവായിരുന്നു. അതിന്റെ എൽഡർ സിബ്ലിംഗ് ഡൈഡ് ഫ്യൂ ഇയേഴ്സ് ബാക്ക്. അപ്പൊ അതിന് ഡയഗ്നോസ് ഉണ്ടായിരുന്നില്ല. ഒരു സഡൻ ആയിട്ട് സീഷോക്ക് വന്ന് ഡെത്തായി. But this child again was admitted with a similar history, and at the end it was proved to be a rare diagnosis, necrotizing encephalitis ആയിരുന്നു. We worked up that case, and that was proved to be ഒരു ജനറ്റിക് ബേസിസ് ഉള്ള ഒരു സംഭവത്തിന് സസെപ്റ്റിബിൾ. മറ്റേ കുട്ടി അത് തന്നെ ആയിരിക്കണം. അപ്പം ആ എപ്പിസോഡിന്റെ അകത്ത് ബയോട്ടിൻ മറ്റേ മെറ്റബോളിക് സാധനങ്ങളൊക്കെ കൊടുത്ത് പേഷ്യന്റ് വാസ് സേവ്. ആൻഡ് ആഫ്റ്റർ സം ടൈം, ഒരു 6 months കഴിഞ്ഞിട്ട് ഷീ സക്കം ടു നെക്സ്റ്റ് എപ്പിസോഡ് ഓഫ് സിമിലർ പ്രോബ്ലം. അപ്പൊ അവർക്ക് 2 കുട്ടികളും പോയി, 2 പേരും ബ്ലൈൻഡ് ആണ്. അപ്പൊ ആ എപ്പിസോഡൊക്കെ കഴിഞ്ഞിട്ട് ഒരു കുറച്ച് നാൾ കഴിഞ്ഞപ്പോ എന്നെ ഭയങ്കരമായിട്ട് അവർ വിളിച്ചു, ഫോൺ ചെയ്തു. അപ്പോ അവളായിരുന്നു മറ്റേ ഞങ്ങളെ കൊണ്ടാടുന്നോണ്ടിരുന്നത്. മൂത്ത കുട്ടിയെ പോയി, ഇതും പോയതോട് ഞങ്ങൾക്ക് ഒന്നുമില്ലേണ്ടായി. അപ്പോ അവര് ചോദിക്കുന്ന, ഒരു കുട്ടീനെ അഡോപ്റ്റ് ചെയ്യാൻ പറ്റുമോ? അപ്പൊ എന്റെ ചോദ്യം ഇതാണ്, അവർക്ക് 55 വയസ്സൊന്നും ആയിട്ടില്ല, അവർക്ക് ലോട്ടറി വിറ്റിട്ടുള്ള ഒരു കാര്യമേ ഉള്ളൂ. അപ്പൊ ഒരു ഫൈനാൻഷ്യലി ജീവിച്ചു പോവാം. അങ്ങനത്തെ സാഹചര്യത്തിന് അവർക്കൊരു കുട്ടിയുടെ കാര്യം ഉണ്ട് എന്നുള്ള സിറ്റുവേഷനിൽ നമ്മൾ എന്താണ് ഡിസൈഡ് ചെയ്യും? എന്തായാലും ചെയ്യാൻ പറ്റില്ല എന്ന് എനിക്കറിയാം.
അല്ല സർ, അത് പറ്റത്തില്ല. കാരണം എന്ന് പറഞ്ഞു കഴിഞ്ഞാല് ഫിസിക്കലി, മെന്റലി ആൻഡ് ഫിനാൻഷ്യലി സ്റ്റേബിൾ ആയിരിക്കണം. അവര് അതില് കൺഫ്യൂഷൻ. കാരണം നമ്മൾ ബെനിഫിറ്റ് ഓഫ് ദ ചൈൽഡ് ആണ് നോക്കുന്നത്. അവര് നമ്മളവിടെ സെന്റിമെന്റ് ഓഫ് ദി പാരന്റ്സ് നോക്കുന്നില്ല. അതുകൊണ്ട് ഈ ഡിസ്കഷൻ ഇഷ്ടം പോലെ വന്നിട്ടുണ്ട്. കാരണം നമുക്ക് തന്നെ കൊടുക്കണമെന്ന് തോന്നും, പക്ഷെ കമ്മിറ്റി വിൽ ഡിസൈഡ് ദാറ്റ് നോ എന്നുള്ള ആൻസർ ആണ്.
ശരി തന്നെ. എന്നാലും അത് കാണുമ്പോൾ
ഡോക്ടർ ബെന്നറ്റ് ഒരു പോയിന്റ്
ചോദിച്ച വേറൊരു ക്വസ്റ്റ്യൻ ഉണ്ട്, അത് എന്റെ ആൻസറും ഉണ്ട്. അതായത് ഈ റിജക്ട് ചെയ്യുന്നതിന്റെ കാര്യത്തിൽ പാരന്റ്സിന് റിജക്ട് ചെയ്യാം. പിന്നെ ഒരു കുട്ടിയെ കാണിച്ചു ഇഷ്ടപ്പെട്ടില്ലെങ്കിൽ റിജക്ട് ചെയ്യാം, പ്രൊവൈഡഡ് ഹെൽത്ത് ഹെൽത്ത് കൊണ്ടുള്ള പ്രോബ്ലം കൊണ്ട് റിജക്ട് ചെയ്യുകയാണെങ്കിൽ അക്സെപ്റ്റബിൾ ആണ്, സീനിയോറിറ്റി നഷ്ടപ്പെടത്തില്ല. പക്ഷേ ഹെൽത്ത് ഇഷ്യൂ അല്ല, കാണുന്നതിന്റെ ഭംഗിയുടെ പ്രശ്നമാണ്, അതുകൊണ്ട് റിജക്റ്റഡ് ആകുകയാണെങ്കിൽ സീനിയോറിറ്റി നഷ്ടപ്പെടും. വീണ്ടും അപ്ലൈ ചെയ്യാം. Only thing is seniority they will lose.
Yeah, that was the point I wanted to raise. Then another thing, Dr. Bennet, we don't have any definite data, but we have an information that illegal or private, I won't call it illegal, even though it is illegal, private adoptions are taking place more than that is happening in this state level. If we try to streamline and authorize private agencies in the proper legal framework, is it not a better idea that go for legally doing adoption in the private sector rather than doing illegal adoption in the private sector? Anyway, it is happening. I think it is something we have to work out.
Sir, about this, actually our awareness is less, but actually the private adoption is there. It is legally accepted. Only
two agencies are there. Two agencies
there. Private adoption agencies
yes,
there.
Yes.
Total in our state around 20 adoption agencies are around. It's not a perfect answer, but around 20 adoption agencies there. In that, 5 adoption agencies are government. 15 adoption agencies are private. But all the procedures are same for both private and government. So it is private adoption agencies there. Only thing is, if you want to get it, you should go with that agency, and the steps are there. No, like court order has to be there to get a child.
I think we have to spread the message to the pediatricians also. As Purushothaman sir said, somebody comes with a illegal idea of an illegal adoption, we ask them to go to the legal agency. They need not go to the government agencies, and they have to have a private agencies also. But only thing is that what is the advantage of that? This child will be having all legal rights. The parents cannot just throw away them, and that is the right of the child to have a family. That is what we are trying to uphold. And for that matter, we need more and more awareness programs. And our pediatricians, I personally feel that when we come across a couple who are going for prolonged years of infertility treatment, we have to tell them that this is an option, probably a better option. They can go for having a good child. I think we must, as a policy, IAP and the pediatricians to take up it in a big way. And I request Bennet to be a torch bearer for adoption, going forward with the principle of adoption in the state. Thank you. Thank you.
Thank you, sir. My brother also is joined. He is a bishop of Punnur. Yes.
Parvati, so many private agencies are doing adoption through the proper legal way. No, isn't it?
Yes, sir.
Isn't
Yes,
it, Bennet? So many, especially in.
Yes, sir. 15 agencies are there.
So that is not illegal. That is legal only.
That is not illegal. That is not illegal. Illegal means
without any
deliveries are there in hospital.
Yes, I know.
Madam,
yes, I know. It was a wonderful talk, Bennet. It was a very nice talk.
Thank you. Ma'am, sir, my brother also joined. He will have some words. He is a bishop of Punalur.
Oh.
Thank you. And at the moment I am in Goa, that is, and I had a program and I could not attend the whole session. Just now my program is over, so I joined. I am happy about the theme that you have discussed, and I have forwarded your message to many people. I appreciate all the
This was personal, this meeting. I wish you all the best.
Thank you. Thank you.
Thank you, sir. എനിക്ക് ലാസ്റ്റ് കമന്റ് പറഞ്ഞ ഡോക്ടർ അശോകുമാർ സാർ പറഞ്ഞ പോയിന്റ് വാസ് വെരി റെലവെന്റ്. എവറി ഇയർ നമ്മൾ ഓരോരോ ഒരു വലിയൊരു പ്രസിഡന്റ് ആക്ഷൻ പ്ലാൻ പറയുന്നതിന്റെ അകത്ത് നമ്മൾ ഹൈലൈറ്റ് ചെയ്തപ്പോൾ ഓർഗാൻ ഡൊണേഷൻ അങ്ങനത്തെ കാര്യം പറയുന്ന മാതിരി തന്നെ ഇമ്പോർട്ടന്റ് ആയിട്ടൊരു മെസ്സേജ് ആയിട്ട് നമുക്ക് നെക്സ്റ്റ് ഇയറിൽ ഇത് കൊണ്ടുവരാം. മേ ബി ബെനറ്റ് സാർ തന്നെ അതിന്റെ ടോച്ച് ബെയർ ആയിട്ട് നിൽക്കട്ടെ എന്നുള്ളൊരു പോയിന്റ്. രണ്ടാമത്തെ കാര്യം, ഐ ആം ഫോളോയിങ് ഡോക്ടർ പ്രവീൺ, സന്തോഷ് കുമാർ സാർ ആൻഡ് IMA. ഡെയിലി എങ്ങനെയാണ് നിങ്ങൾക്ക് ഇത് പറ്റുക എന്നുള്ളത് അത്ഭുതത്തോടു കൂടി നോക്കുകയാണ്. ഓരോ ദിവസവും നിങ്ങളെ വെബിനാറുകളും ഇതൊക്കെ ഹൈലി ഇൻഫോർമേറ്റീവ് ആയിട്ടുള്ള കാര്യം ഇതെങ്ങനെയാണ് കൊണ്ടുപോകുന്നത് അത്ഭുതത്തോടു കൂടി നോക്കുകയാണ്.
പ്രവീണിന്റെ ജീവിത പേഴ്സണൽ ലൈഫ് മാറി കിട്ടി അതുകൊണ്ട്. Praveen fully dedicated. Not only this, sir, he is doing the job of our COVID care also with the government.
അതിനൊപ്പം കുറെ യൂട്യൂബും ഒക്കെ നടക്കുന്നുണ്ട്. അതും വളരെ എക്സലന്റ് ആയിട്ടുള്ള ഇൻഫോർമേറ്റീവ് ആൻഡ് വളരെ ഇതായിട്ടുള്ള യൂട്യൂബ് സാധനങ്ങളും ഒക്കെ കാണുന്നുണ്ട്. എല്ലാം ഫോളോ ചെയ്യുന്നുണ്ട്.
Thank you, sir. Thank you. So, Bindusha madam, I can.
Okay, if there is nothing else, we will wind up the program. Thank you, Bennet sir and Pradhananda sir for the excellent sessions, and thank you, Purushothaman sir, and all the senior members, Parvati madam, Bishop sir, for giving their valuable opinion, and also especially thanks to Ashok Kumar sir for his input.
Okay.
Thank you, madam.
Thank you.
Thank you all. Thank you. Thank you, Pradhananda sir, once again.
Thank you, Dr. Praveen.
Thank you, Bennet sir. Thank you, Bindusha madam, Purushothaman sir. Thank you. Good night. Bye.
Good night. Good night.